right. Okay. Thank you, everyone, for joining us today for the first webinar of our Improving Childhood Obesity Care, a Grow Healthy series. I'm Laura Boyer. I'm a nurse practitioner with the Metamore Institute and Grow Healthy here in the Pennington campus. I will be moderating the training series and looking forward to engaging with all of you. What is Grow Healthy? Grow Healthy is an evidence-based public service initiative grounded in decades of childhood obesity prevention and treatment research from Pennington Biomedical Research Center. Pennington Biomedical is a world-renowned research center that promotes metabolic health and elimination of metabolic disease through scientific discoveries. Visit our website at growhealthy.org for more information. Grow Healthy will be hosting a series of webinars, with this one being our first. Our next webinar will be on May 14th with Dr. Katie Queen from Our Lady of the Lake Children's Hospital, where she will be presenting on obesity medicine. In July, Dr. Zubaida Noor Hanipa will be presenting on the 17th, and her presentation will be an overview and efficacy of metabolic and bariatric surgery in adolescents. Grow Healthy has recently launched a childhood obesity prevention, evaluation, and treatment toolkit for providers that is available online through our provider hub. This toolkit is a refresher or an introduction to the AAP's clinical practice guidelines, which one of our presenters, Dr. Staiano, co-authored in 2023. We will place a link in the chat to download this toolkit. Grow Healthy is also excited to announce the Grow Healthy Childhood Obesity Prevention and Treatment Conference. Please save the date for September 18th and 19th. The conference will be held in Pennington Biomedical's Conference Center in Baton Rouge. More details and an agenda will be shared soon. Dr. Staiano, Dr. Button, and Ms. Ulmer have no relevant financial relationships, and all financial relationships have been mitigated. I would like to introduce everyone to our three presenters: Dr. Amanda Staiano, Dr. Alyssa Button, and Ms. Angèle Ulmer. Dr. Amanda Staiano is a faculty member and director of the Pediatric Obesity and Health Behavior Laboratory at the Pennington Biomedical Research Center. Her primary interest is developing and testing family-based healthy lifestyle interventions that utilize innovative technology to decrease pediatric obesity and its comorbidities. Her research has involved over 2,500 children and adolescents, including randomized controlled trials and prospective cohorts, to examine the influence of physical activity and sedentary behavior on body composition and cardiometabolic risk factors. Dr. Alyssa Button is an assistant professor duly appointed in the departments of psychiatry and pediatrics, and she provides services as a licensed clinical psychologist in the Healthy Lifestyle Center at Children's Hospital of Richmond at VCU's Comprehensive Pediatric Obesity Treatment and Research Center. Her research interests are in the design, implementation, and evaluation of intensive health behavior and lifestyle treatment programs for child obesity treatment, particularly in underserved populations. Ms. Angèle Ulmer is the Pediatric Nutrition Manager for the Pediatric Obesity and Health Behavior Lab at Pennington Biomedical. She supervises professionals implementing intensive health behavior and lifestyle treatment programs for childhood obesity treatment. Angèle is an experienced registered dietitian. I'll now pass control over to begin the first presentation.
All right. Hello, everybody. So how do I advance to the next slide then? It is a pleasure and honor to spend the next hour with you. As Laura introduced, my name is Amanda Staiano, and what we're really excited about for this webinar is bringing together myself, Alyssa, and Angèle. Collectively, we've worked with thousands of children and families, either directly or indirectly, within the context of obesity care and weight management. We, of course, have approached this from a scientific research perspective, but as you'll see, our work is very pragmatic. So while we're sharing the best practices and what the scientific evidence says and recommends to do, we are very realistic and pragmatic in what we do as well. And so we are giving you strategies and tools that have been used in clinical settings, and we are here to help you and support you. So I hope you take some helpful lessons away that you can implement immediately in your practice or with the families that you work with. But I hope this also spurs some ideas, and you're welcome to reach back out to us if you'd like further support, as we are, through Grow Healthy's help, getting our evidence-based programs out to clinics and parents and teachers. We are here to help you and support you to try to disseminate this. So the agenda today is we will spend some time briefly touching on the science behind intensive health, behavior, and lifestyle treatments. And then Alyssa will share with you some high-level strategies for motivational interviewing and conversations about weight. And Angel will wrap us up with strategies to implement this intensive health, behavior, and lifestyle treatment in clinical practice. And we'll have some time for case examples. And we, of course, welcome your questions and feedback towards the end of the presentation. I think I might have to say next slide because I'm not sure how to advance on my own, but I'll say that so we can keep it going. So the learning objectives today is to talk about IHBLT. And for those of you who aren't quite as familiar with the clinical practice guidelines, I understand it's a lot of letters, but we're going to break it down to you so you truly understand what IHBLT is. We're also going to talk about motivational interviewing. Keep in mind, to become a full-fledged MI, it typically involves a couple days worth of training, but we have gleaned what we think is the most important techniques of MI to provide that to you. And then I encourage you to look out for some additional training opportunities later this year in conjunction with our Child Obesity Conference, where you can get even more hands-on practice with MI. And Angel will talk about some high-impact behavior changes that if you're not able to do IHBLT full-blown program, there are still some very important health behavior change strategies that you can start implementing with your patients. And so we expect today that you will come away with a better understanding of IHBLT and strategies to implement. We will talk about how to use patient-centered conversations and be sensitive and respectful about patients' weight. And ultimately, we'd like to help you identify the small and high impact changes that you can help families to implement. So going on to the next slide. IHBLT. So this is a new acronym for a program and an approach that many of you are already well familiar with. That's centered in dietary counseling, but it focuses on a number of behavior modifications to help families with their weight management journey. So as you can see on the next slide, Laura mentioned the American Academy of Pediatrics clinical practice guidelines. If you're on this call today, clearly you have some passion or interest in weight management. I encourage you to take some time to go to this website, aap.org, Obesity CPG, and read through the summaries and the materials that the AAP have put forward. I had the honor of participating in these clinical practice guidelines, and it took us about 6 years to develop them. And the reason for that is we first launched this large systematic review of all of the scientific literature related to pediatric weight management. We reviewed thousands of published studies, and we used high standards for rigor for including studies into these guidelines. They needed to be randomized controlled trial, have a comparator group. We also required that they were done in clinical settings. So these trials are not just done in research labs or even at academic centers, but they were actually done at pediatricians' offices and other healthcare settings in order to be included in the review. So ultimately, we narrowed it down to 400 studies that inform the clinical practice guidelines. This is the first time the AAP said that these are actual practice guidelines, which means not only are these suggested practices, but these are actually the expectations for pediatricians and pediatric healthcare providers, because now we have a mountain of evidence showing that these treatments are safe and effective for children and adolescents. So I encourage you to read through it. There are also some really excellent evaluation guidelines as well in terms of evaluating comorbidities and tracking children's health over time. So then moving on to the next slide, I also wanted to mention the CPG aligned with the U.S. Preventive Services Task Force recommendations. There's a lot of overlap and alignment with these two. What's really important about the Preventive Services Task Force recommendations is that under the Affordable Care Act, recommendations that meet a grade A or a grade B in terms of the amount of scientific evidence behind them, and that the benefits outweigh potential harms. Those that get a grade A or a grade B, it is expected that insurance companies will pay for these treatments for patients. And so that is very powerful, and that is what helps address some of the sustainability concerns of people saying, well, how are families going to be able to afford all these visits with dietitians? How are the clinics going to be able to offer it if they can't collect on these? That's what makes these task force recommendations very powerful. And so these recommendations have been around for several years, but in 2024, they did another review of the literature and again released the recommendation that the task force recommends clinicians provide or refer children and adolescents 6 years of age and older with a high BMI to comprehensive intensive behavioral intervention. So that aligns very nicely with the clinical practice guidelines that you see on the left. One thing to note about these clinical practice guidelines, we're specifically today talking about motivational interviewing, which is something that any healthcare provider can do, as well as intensive health, behavior, and lifestyle treatment, which would typically involve some type of nutritionist, could be a dietitian, but it could be a variety of healthcare providers. As you heard from Laura, in a couple of months, we'll talk about pharmacotherapy. In the summer, we'll talk about surgery. This is not meant to be a choose one. MI and IHBLT is meant to be the foundation offered to all patients with obesity. And then some based on eligibility criteria and the needs and preferences of the family may also be offered pharmacotherapy or surgery. So now if we move on to the next, this is the one slide I wanted to show you to really focus on the numbers and the science for a moment, to really establish some credibility with you on where this evidence comes from. So this table is drawn from the clinical practice guidelines. And what the numbers are is the numbers of studies that I mentioned that we reviewed that fit into these various categories. So all of these studies use lifestyle and diet as an intervention. And again, it was all done in primary care or a healthcare setting. And so starting up at the top, you can see the studies that compared an intervention versus a control group. So these would be families that didn't receive the intervention. There were 20 studies that delivered less than 5 hours worth of dietary and lifestyle counseling. And then 26 delivered 5 to 25 hours, 7 delivered 26 and higher, and then there was one study that delivered over 52 hours. So it's typically over the course of the year. So for a 52-hour program, that's a family coming to meet a nutritionist or a trained provider about once a week. And then for these others, it might be every other week, once a month, and so on. So what I want to show you here is that first red box, the percent with any success and that says time 2. It's actually an error in the guidelines. It should be time 1. So this is the first time that these trials are measuring outcomes. It could be about 6 months in, sometimes it's 12 months in. And you can see that 25% of the trials that delivered less than 5 hours worth of intensive health behavior treatment found success. What does success mean? It's typically a statistically significant reduction in that child's weight compared to the control group. Sometimes there's actual bar that they're trying to reach for in terms of clinically meaningful weight loss, but about 1 in 5 or 1 in 4 of those studies did find success. And then you see this dosage. As you get families to do more hours, more of the trials are showing success on average. And so all the way up to the 52 or more hour intervention, 100%, that study did show success. The reason I wanted to highlight this is for a couple of aspects. One is you can find success with lower dosage interventions. And that's something we wanted to share with you. Those of you who think, I can't do a 26 contact hour intervention, we don't have enough staff capacity, the families aren't going to come. Something is better than nothing. And so even if you start with a lower dosage intervention, having that family meet with the dietitians a few times, that is important rather than offering no intervention. So starting with the capacity of what you have and then trying to start ramping up over time. I think that's important to share. And then the other thing is some families will find success with lower contact hours as well. And we see variability within the trials too. You're more likely to see success if you can get that family coming more regularly to see a dietitian or a trained nutritionist, especially at that higher end. But do keep in mind, we need to do the best we can as we're all striving towards more intensive, higher frequency programs. And then on the far right, is percent with any success at time 2. So oftentimes this will be later, a year or 2 years in the future. And you can see a similar story there. There was some success with the lower dosage, but really it's the programs that provide higher frequency, meeting every week, meeting every other week with that dietitian. That's where you start to see some sustained weight reduction for the child. And that's where you really start seeing the clinical changes in their comorbidities and in their lab values. And so now we'll move on to the next slide. This is to highlight the conclusion of the Preventive Services Task Force. If you'll click one more time to get my red bars up there, there we go. And so this task force concluded that weight management interventions led to improved weight status in children and adolescents that ranged from a modest effect for behavioral interventions and a couple of the older generation medications, as well as liraglutide, to substantial effect sizes, semaglutide and phentermine topiramate, with no evidence of serious harm and modest impact on health or intermediate cardiometabolic outcomes. And so again, and this is important for families and children to know as they're starting these interventions, what is the expected outcome. For behavioral interventions, we may see a 5% reduction in relative weight, and oftentimes, just like in adults, that 5% reduction can be enough to see some other health improvements. But for children and adolescents, we really want to start changing some skills, building skills, changing the environment, and putting some things into place to help the parents and child to be successful, not only while they're in the program, but as they transition into adulthood and beyond. So while weight is an important marker for health, we are also looking at changes in their behaviors, changes in the environment. And that's often what's really important to the families too, and changes in the child's quality of life. But it's important as we have more and more treatments and medications available to make sure people have realistic understanding of how much weight they could be expected to lose. Again, there's variability, but we need to put that into context with families so that there isn't setting up themselves up for disappointment, for example. So now we can go on to the next slide. And what I'll do now is talk specifically about what is intensive health behavior lifestyle treatment. This is an evidence-based tool that is part of comprehensive obesity treatment. And as I said earlier, according to the clinical practice guidelines and the task force recommendations, this should be offered to all children with overweight or obesity. The strongest evidence, as I showed in the table, is for 26 or more contact hours, typically over the course of several months to a year, of family-based multi-component treatment. So if we move on to the next slide, this is a graphic that shows you how this can be broken down. And one thing I want to point out here is these IHBLT programs have been shown to be effective in a variety of delivery methods and hybrid approaches. And so again, when you're thinking about this from a pragmatic perspective, you think about what is your current capacity, what team members are available to you, what facilities do you have, and also what are the families looking for? Are families interested and able to do virtual programs? Do they really want to physically come into your clinic? Is there space for group sessions, for example? But the who, when, what of this is the patient and the family. The scientific evidence supports the family approach. So regardless of the age of the child, including that parent or an adult caregiver, is very important because oftentimes they're making food purchasing decisions and helping to dictate that child's schedule and what they participate in. Building that multidisciplinary team, whether that's something you can provide in your own clinic, if you need to look at a broader network, if you need to look at community partners, but trying to bring in that nutrition expertise, physical activity, some sleep, also reading those clinical practice guidelines and understanding when and how to refer that patient for different evaluations and assistance, thinking about the holistic child. When upon diagnosis, as that child crosses the threshold into above the 95th BMI percentile, that is when it's suggested to look at these IHBLT programs and resources. And many start earlier, between the 85th to 95th as well, at the overweight category. What does this entail? There is some health education and nutrition education, but it is not about talking to the family or telling them what to do. It's about working together using motivational interviewing and ultimately helping to build skills about how do you set SMART goals? How do you help change the child's environment to build towards success? How do we modify behavior? There have been successful trials done with groups of families, with individual families, meeting with that counselor or provider or combination, face-to-face or virtual, in a variety of lengths and durations. Again, the ideal would be 26 or more hours over several months, but we will help work people towards that ideal. So now moving on to the next slide. These are some things to consider, especially if you're starting fresh and don't have an IHBLT at your clinic. But even if you do have some amount of dietary counseling going on, here's some things to consider. Team role and responsibilities. These sorts of programs really benefit from a champion, whether that's the pediatrician or the dietitian or some other clinic administrator, and baking that into other metrics that the clinic is trying to meet too, whether that's metrics I see someone on from Blue Cross Blue Shield, so metrics with the insurance company or whatnot, to really bake it in as part of the offerings of that clinic. Doing ongoing staff trainings, that's one thing Grow Healthy is trying to do today. Continuing education opportunities, assessing office physical space, capacity, things you can build within your EHR like alerts or templates for surveys, reminders about who's eligible for the program, and so on. And so if we'll go on to the next slide. Identifying billing codes, and part of the toolkit that Laura mentioned earlier has actual billing codes that have worked here in Louisiana with a variety of our clinics and physicians. And so using those billing codes, understanding what to do in terms with Medicaid, which we have shown will pay for these weight management services and dietary services, as well as commercial plans too, and a variety of commercial plans that are paying for these services so that the families don't have to pay out of pocket. And here are a few other things to consider. And in general, a weight bias and stigma training, and we can provide you some suggestions there. But to make sure every member of the healthcare team, from the person that the family talks to on the phone to schedule visits, all the way through the providers they meet with, is very aware of weight bias and stigma and uses respectful language with the families. So moving on to the next slide. This is the final of mine, and then I'll pass this on to Alyssa. What do you do if you don't have an IHBLT program? According to the clinical practice guidelines, you deliver the best available intensive treatment that you can while you're building collaborations with other specialists or identifying other programs that you can refer to. But what's really important is that the medical provider should stay involved. So this is not writing a prescription to send a patient back to the community or off to do a program. This needs to be a clinic community linkage that clinician can help monitor and support the healthy growth and development of the child. And so now we'll move on to Dr. Button, who will give you some really concrete strategies that you can use with your patients.
Thank you. Motivational interviewing is a tool that all providers can use. It's not an intervention that has to be time intensive. It can just be brief in your interaction. So next slide, please. Healthcare providers often feel powerless and frustrated when patients don't seem to care and there never seems to be enough time in an appointment. These feelings are often when we see resistance from our patients, and when we see this resistance, what we do really matters. If patients are talking more about why they can't or don't want to change, they'll be less likely to change. Motivational interviewing offers an alternative approach. It's a person-centered, collaborative conversation style to strengthen a person's own motivation and commitment to change. It's generally a quiet and eliciting style where the patient does more talking. The provider's job is to support their autonomy and collaborate on goals that are meaningful to the patient. Not all concerns can be resolved at once. Maybe this conversation opens up some willingness or confidence to set another appointment to address the concern. Next slide, please. There are some core principles of motivational interviewing to cover. The first being ambivalence, which often precedes change. Candidates for change are usually ambivalent. We can empathize with the comfort and sticking to familiar routines while also highlighting discrepancies between values and behaviors. Something along the lines of, I understand your family has a busy on-the-go schedule and making time for having more meals at home is important to you. When the patient leaves their appointment, they're alone and it's up to them to change or not to change. So once we release ourselves of the duty to change people or make them change and realize that the onus is on them and they're in charge of their own decisions, this is autonomy. Then we're free to listen, understand, and empower them to make decisions that are consistent with what they want. And we do this through affirming their abilities, evoking motivation, collaborating with the patient to develop plans to move them closer towards their goals. And we use change talk to reflect patient desire and commitment. And so next slide, please. We can do this through change talk and sustain talk. So change talk is what we as providers really want to encourage. So when you're starting to hear these, we call them darn C's. These are things that we want to focus in on and ask some open-ended questions about to get the patients really using these types of statements. And so these statements include desire, ability, reasons, need, and commitment. So I desire to lose weight. I'm able to park farther away and get in more steps in my day. My reason to change is because I would probably be able to play longer with my friends. I need to lose weight so that I can be healthy, and I am committed to sticking to the plan. And in these conversations, there will also be some sustain talk. So sustain talk is a patient's reasons for why they can't make this change, why this is not a good time for them. This type of talk you might hear when somebody doesn't yet recognize a problem, or maybe they're not feeling confident in their abilities at this time to make those changes. And so we want to use like our good practitioner listening ears. And again, we can be empathetic to sustain talk. There is comfort and real reasons for why it might be difficult. And we can also really try to focus more and shift the conversation more towards that change talk by using some of these strategies on the next slide. Okay, so one way to kind of keep some of this motivation going for those change talk, we can use these. Motivational interviewing has so many acronyms, so these are called ORs. These will be your open-ended questions, affirmations, reflections, and summaries. So once you're starting to pick up on those change talk statements, we can get the patients to keep talking about those by using open-ended questions. So these are questions that cannot be answered with a simple yes or no. So instead of asking, does your family eat fast food? You might get a no. You can ask, what does a typical dinner look like at your house, to get some more information there. These encourage families to give more detailed responses. And then the next one we have are affirmations. So these are statements that recognize the patient's strength. It shows that you're acknowledging some of the efforts that they've already made. So an example here could be, you have an awesome attitude about making these challenging changes. I think there's always something that you can affirm in the patient. I know that this is really important to you. You made this appointment and you attended it today despite all those busy things that you have going on. And then we get into reflections also. So a lot of times the patients just want to be heard, and it can be really powerful and effective to just show that you're being a good listener. And also, it can be helpful to hear through sometimes patients might be talking and not reflecting so much on what they're saying. So listening to it coming back from their provider can be a good way for them to reflect on that as well. And it shows that you've been listening, actively listening. So there's simple reflection. So really just basically restating what the patient said. You're having a hard time making time for physical activity, or it could be reflecting content or feelings. So something like you're very interested in finding new breakfast ideas. And then you can just continue to go from there. And summaries are maybe after you had a conversation for about a minute or two, you really want to just summarize what you've spoken about, make sure that you're on the same page with the patient and you understood what they're saying. And especially with reflections and summaries, never be afraid that you're going to have missed something or misunderstood something. This is a really good opportunity. And if you got it wrong, the patient will typically tell you, you know, that's not what I said, that's not what I meant. So it's really helpful to make sure that you are actually on the same page. Next slide, please. Okay, so before I finish up with motivational interviewing, if you're going to take anything away from these 3 slides to help your patients consider change, it should be really empathy and active listening. Those 2 things are really the spirit of motivational interviewing, and they seem so simple, but they can really go a long way in helping the patient to feel heard. Okay, so next slide, please. Conversations about weight might be uncomfortable, or maybe you might be nervous or the family might be nervous, but they're really important to have. And these conversations will likely look different whether you're talking to the parent or the child. In both scenarios, you want to ask and get permission before discussing weight. So you might say something like, I have concerns about your weight. Is that something that you're open to talking about today? And then respecting the family's decision. Maybe if they're not open to talking about weight today, they might be open to talking about how they can fit in more activity into their day, or how they can work on finding nutritious foods throughout their day. With parents, you might want to ask too, is there somebody else who should be a part of this? Is there somebody who we should not have included in this conversation? And with parents, it's really helpful to talk about how to get the whole family involved in the healthy lifestyle change. We're not trying to make changes just for this one kid. We want this to be a whole family thing. We want the child to feel supported. And really, these things that we recommend are healthy for everybody to do. And it's easier on the parents that way as well. And to really help with a positive conversation, get some good momentum going, we can focus on some of the things that the family are already doing really well, or early efforts that they've already started. Did they bring a water bottle to their appointment with them? Fantastic. You're already working on getting your water in. What's next? And then with children, it's really helpful to not focus on a specific number. Weight is just one measurement like any other, just like blood pressure, just like cholesterol. It's really just a measure of their health. And so with kids, what we want to focus on is health behavior. So again, increasing nutritious foods, decreasing less nutritious foods, not completely getting rid of them, but how can we maybe make some swaps throughout the day, some goals on physical activity. I know a lot of the kids that I see are motivated to come in for their sessions because they want to be a better athlete. They want to run really fast, keep up with their friends, feel better in their clothes. So those are the types of things we talk about, is which behaviors will help you get closer to those goals. Next slide, please. Okay, and then like Dr. Siano mentioned, it's also important to adopt these non-weight stigmatizing practices. And one way to do that is just being mindful of the language that we use with our patients and our personal and daily lives too. And so these are just some of the things that stand out, but I'm sure as you go about your day, you'll hear some others. We really want to avoid saying obese child, overweight child, normal weight child. And the purpose behind this is that there's a lot more to these children and a lot more to these patients than just their weight status. So person first language would put the child before the diagnosis. So child with obesity, child with overweight. And I also really like to advocate for using child with healthy weight versus normal weight, because then we're saying that if it's not a normal weight, then there's something abnormal about this kid, and that can be pretty hurtful. And so some of these on the right side are pretty just some recommendations for how to be more sensitive. So avoiding things like fat. I don't like saying that as an example either. And I really like the two at the end. Instead of talking about a child's weight or shape that you notice, you can talk again about those good behaviors that they've started practicing, really encourage the behaviors. And then it's very important to be a good role model. So the way you talk about yourself, the way you talk about other people, the kids are picking up on that. They're listening to what you're saying. And so just be a good role model in your language as well. Okay, thank you so much. I think that will bring us to our next slide for Anjal.
Yes, thanks, Alyssa. So we'll talk about some strategies that you can implement today in your clinic to help make some of these behavior changes. Next slide. So for setting goals, and Alyssa hit on some of these points already, we do want goals to be SMART goals, right? We want them to be specific, measurable, achievable, relevant, and time-bound. But what I want to focus on here is specific for these families. All your patients are going to come in with different goals, different lifestyles. So setting relevant, specific goals for them is going to help them be motivated to make some of these changes. We want to involve the entire family in goal setting because we aren't making healthy lifestyle changes for one piece of the family. We want the entire family to be healthier. That's going to make achieving these goals for the parent involved and the child involved much easier if you're all working towards the same goals. And really that's individualizing it for that specific family. Breaking down large goals into smaller steps so that they are more achievable. A lot of people will come in with large goals. So helping them understand what is realistic for their particular body, their particular lifestyle can help them not be overwhelmed or not get discouraged by not seeing what they believed they could achieve over this time, but helping them set something that's really realistic and still going to give them some really great results. And then celebrating achieving these small goals. So really implementing praise within your sessions, within your meetings with these families. And like Alyssa said, anything you can praise them on that is working towards these healthy behaviors makes them feel better about themselves, better about their goals, and more motivated to continue on with them and more motivated to talk to you about things that they're doing well and things they might not be doing well with. Next slide. So what are some small changes that make the biggest impact? Because if you aren't able to see these families for 26 hours over a year, you might want to focus on what's going to make the biggest change within that person's lifestyle to see some of those weight reductions or reductions in some of their lab results. So the first one is going to be reducing sugar sweetened beverages. So that'll include sodas, juices, sports drinks. It's really just excess calorie intake and encouraging liquids that have either 0 calories or offer more nutrients, such as water and milk. And one thing to consider here is diet sodas or diet drinks, which is not something that we necessarily recommend, but as a better option for the full sugar, full calorie, it is something like a stepping stone to having more water in their daily intake. So it could be the first step in a direction to making these changes for these families. Minimizing highly palatable processed foods. And this includes foods that are more packaged, so chips, pre-made cookies, things that are highly palatable. They're marketed to children, they're marketed to families, they're inexpensive, and they're hard to put down. So companies are spending billions of dollars to make them more, to make them tastier, to make them easier to buy. All that is going against families. So what you can encourage them to do is aim for whole, minimally processed foods, but really limiting your access. So not having them in the household, having them less accessible within the household, not having giant Costco-sized versions of these foods. Any way to help these families not be tempted to have that entire bag of chips or cookies. Just trying to make it easier for them to choose the whole foods. Increasing family physical activity. Physical activity is typically more fun with a group. So getting both the parent and child involved, getting siblings, the other parent involved is going to make them more likely to do this activity and help them change their routine. So if the entire family is used to coming home after school or work and sitting in front of a screen, setting the goal to do as a group, to get out of the house, to do something at home that gets their movement up, can help build that activity within their lifestyle. And then you can see some strategies here, like family walks and different things to do on the weekends. But some things that are inside are just something as simple as playing a song and doing a dance break, or doing any active games within your house. And then lastly is improving sleep hygiene. So poor sleep is linked to increased appetite, cravings, and weight gain. It really affects your mental capabilities, so your choices will be influenced by here. So being really good about your routine with your sleep schedule. So consistent bedtimes, even on the weekends, as much as you can allow, limiting screens before bed, and really creating a solid bedtime routine for not only the children, but the adults in your household. Next. And really highlighting personalizing the treatment. So we want to individualize this as much as possible. Every family is different. Everyone has different goals, different lifestyles. And as you probably know individually, personally, but also with your patients, everyone's schedules are really hectic. Everyone has different needs, home environments, multiple children in the household, financial circumstances. So all those are going to be influencing how these families are going to be successful with their behavior change. So really listening to them, seeing what their priorities are, and seeing specifically what they are able to change and help them reach that goal. Also considering access to food, not only just for the family, if they can afford groceries, where they're grocery shopping, but also for older children who might have access to food outside of the home. So at school, vending machines, convenience stores, where are they getting some of these meals and extra calories? And then lastly, all of this needs to be discussed during planning sessions and considered when setting your goals with your family. So individualizing it as much as possible, like I said, so the family has something that they want to work towards that they perceive as achievable, and hopefully you'll find success with that. Next slide.
And so our homework for all of you is to first go to the Grow Healthy website, check out our provider hub. There's a lot of excellent resource on there for you, a toolkit, links, and we'll continue building this over time as well. So we encourage you to spend some time there. Also, I wanted to draw your attention to the Next Steps guide that the American Academy of Pediatrics publishes that you can access. This goes into even more detail of what Angel was sharing about topics that you can use in the primary care visit or for dietitians. It's patient friendly, so there's information on one side to show the family and information on the other side of the flip chart to remind the healthcare provider of what to cover in those topics. And it's a really nice start if you don't already have IHBLT. And then, of course, the clinical practice guidelines, too, that I mentioned. There's some good resources on there. There are patient handouts you can print, information about, how to bill, how to implement all of this into your clinical practice. But again, we do recommend that you start with Grow Healthy because these are resources that we designed specifically for Louisiana healthcare providers in mind. And so as Brooke shared, you're welcome to enter questions or feedback in the chat and the Q&A. We'll give some time to see if people have questions. And we also prepared some case examples too, if we have time to walk through some examples of common scenarios you might be faced with in the clinic and how to approach those. So while people are thinking of their questions, we could go ahead and start with the first case.
So for our first case example, Kate, who's a 14-year-old female, is disappointed with her weight loss status. She thought she would be down 20 pounds within the first month. She complains that the medication is not working for her or the lifestyle changes and thinks that she is failing. So how would you address this? You can click it once more. So some suggested responses to this is talking about slow and steady wins the race, helping Kate and her family learn what is a realistic weight loss goal. So then they're not set up for failure. 20 pounds in 1 month, especially for a child, is unrealistic. So we want to set healthy goals for weight loss, focusing on nutritious foods and increasing physical activity, and discuss how everyone reacts to medication and lifestyle changes differently. So what she anticipates and what's realistic may be different, and helping them kind of understand that before they leave that session. Also helping them focus on some positive changes that they do notice that may not be tied to weight. So has their sleep improved? Do their clothes fit differently? Do they feel different internally? How about their mood? Something to help them have like a positive take on what that month has achieved. Next slide.
Okay, we have another case here. So Theo is a 16-year-old male who calls himself fat, stating that even his father and younger siblings make fun of his weight. He states that he hates how he looks and he feels hurt by his family's remarks. These cases always make me so sad and hurts my heart to hear. Does anybody have any recommendations or like potential approaches that they might use with this patient? Okay, I will give you the answer. If you could press next, please. So you can really empathize with this patient. You can let them know that this is difficult for you to hear and it's not fair. And then remind them that weight is a matter of health. We don't care about shape or size. The appearance is not what is important to us. And just emphasize that it's important to be kind to yourself and that this can be hard work, and it really takes a lot of support. And then to try to kind of bolster their motivation, bolster their mood, you can also use those affirmations again to praise them for one of their like health behaviors that they've been working on recently that they've been doing a really great job with.
Thank you. Okay, can everyone hear me? It looks like we have a question in the chat. The question is, how would you go about recommending obesity care if the parent is asking for their own treatment options?
So certainly when we work with family medicine practitioners or those that see adults and children, that can be an ideal scenario because those practitioners can provide treatment to both the parent and child concurrently. One thing to note about these intensive health behavior lifestyle treatments, these are family-based treatments. And oftentimes the parent is also coming in at a high BMI and is interested in setting their own weight goals and health behavior change goals. That's very powerful in the scientific literature. If the parent and child or children are in this health journey together, making goals together, monitoring their weight together. And so there is certainly a way, even within a pediatric clinical context, to be offering treatment to the parent as you're concurrently working with the child. Where we, of course, run into challenges is with reimbursement and the way our healthcare system is set up to separate the child and the parent's healthcare. So if you're in a situation where you're in a pediatric clinic, do keep in mind that you can still use this family-based approach so that parent can often actually be successful themselves in losing weight and improving their health. But that's where it would be helpful to find out what other community resources are available, and even to better understand the landscape for adult obesity treatment in your community. If you have board certified in obesity medicine physicians that are available, that's helpful to know. That way you can share some suggestions to that parent if they are really interested, for example, in being prescribed obesity medications or even considering surgery. You have some of that intel that you can help to connect the dots for that parent. Alyssa or Angel, would you have anything in addition to that? Okay, well, hopefully that's helpful. And Laura, feel free to ask any follow-up questions. And then Zuby, thank you for your comment. As clinicians, how can we address bullying at school for a child with obesity? Alyssa, do you want to take that one on?
Sure. So when I'm talking with a patient who's experiencing bullying, we know that bullying is a very high risk factor for later disordered eating. And of course, we're concerned about mood as well. These patients already are at higher risk for depression and anxiety. So one of the things I like to check first is make sure that there's somebody trusted at school, a trusted adult, maybe a counselor or a principal or a favorite teacher that the child feels safe talking about this with, so that they're not like if there was an emergency situation at school, they would have somebody to go to there. I like to make sure that the parents are aware as well, just to make sure that if it's something that could be addressed with some extra support, we have the right people. Sometimes that's not enough, unfortunately. And so while we can't make the bullying go away, those are the situations where I like to refer out to like a mental health counselor, somebody who can help the child deal with and cope with that type of teasing and bullying. And sometimes I have time to do this in my sessions because I'm a psychologist, so it falls in my realm, and I understand it's difficult for other providers, but I like to talk about too things that they feel proud of for themselves or other sources of support. I really like to get a better idea of where else can they get support. But it would be very appropriate to make a referral for mental health counseling to deal with that.
I also put in the chat a way to get in touch with us. So as I said previously, if you're interested in learning more and getting more support, the Grow Healthy team is working to get our programs, weight management programs, tools and resources out to the community throughout Louisiana. So we encourage you to reach out to us. We do have a family weight management program that we're working to package so we can disseminate it throughout the state. So we'd love to talk with any of you who would like to try this out. But we can also give you some more individualized suggestions too, based on your situation and your clinical practice. I see Brooke has left a link to the survey as well. That would be very helpful for us. This is our very first webinar of this type. And so we appreciate your participation. And I think on that note, we'll pass it back to the Grow Healthy team to wrap us out.